Appreciate the reminder. I'm doing it now.
Perfect.
Recorded for posterity. Anything you say will be remembered forever. Okay, I'm gonna share my screen. What I thought we'd do, kind of like we usually do, is I'll go through the 2 chapters, kind of give you my highlights on them. I'm not using the same slides. If you looked earlier in Blackboard, earlier meaning more than an hour ago, you won't see the slides that I'm going to use. Those are the slides that we had in the course. I think Dr. Nickpour wrote them. They don't look exactly like publisher produced slides. So I made different, I didn't like them. And last week I thought that was so boring to me. I'm just reading these slides to you. I hated that. So I made my own slides, but they still cover the same thing. So I'm going to move it along. If you need me to slow down, just say so. Okay, here we go. So the first chapter is, I'm doing 2 things at once, sorry. About creating a culture of safety. And they even start off by saying it, although as I read through it last week, I was like, well, this is a lot of the same material we've already covered. But it's in a different, kind of a different lens on it. And then, I realized when I came back to refresh for today that they say right off the bat, oh, we're still talking about the Tenerife, air disaster that you saw in chapter 9. So, I mean, they do. There's even a couple places I caught, not so much in this one, but in chapter 16, where you actually get some information that is different. It is conflicting with what they've presented in the book earlier. It isn't anything significant, but I thought, well, that's interesting. They've got 2 points of view right here in the same textbook, but we'll just sort through it. So these are just very bullety kind of slides. They go over, in the beginning, kind of what is the culture of safety and how safety affects patient outcomes and staff morale. That's kind of the point of the chapter. I can probably make, is that hard to see? Because I'll bet I can make this better. If I do this, ooh, then I can't see you.
It's fine the other way too.
You can see it?
Yeah, it was good.
All right, I can make this smaller. This little side pane smaller. Yeah. All right. So they go into the concept of high reliability organizations. And this concept came in the 90s and early 2000s. It really took off. And they mention a couple of the key players in there, but it's about the whole idea that an organization is committed to having reliability. Reliability, you've probably had research classes and stuff to know the difference between reliability and validity. Reliability just means reproducible, every time the same, all the time, always the same. So that's a key concept in healthcare safety, is it's you're trying to reduce variation. You want reliability, meaning every time you do that process, it goes exactly the same way. And they don't mention this, but that whole idea of maybe you've heard in quality 6 Sigma. That was a process that came out with J. Edwards Deming and Chrysler and some other authors, way back, like 70s and that. And they took it over to Motorola, took it to Japan, and I mean, it really got going. But the idea was statistical quality control, and they wanted the variation limited so that it was, if you think of standard deviations, 1 standard deviation, 2, 3, 4, 5, and the ideal would, in their mind when they were writing this stuff, was you should be at 6 Sigma, 6 standard deviations of reliability, that everything within 6 standard deviations of that curve is the same. It's a little hard to visualize that, but that's where the name came from. So that's why they talk about reliability and getting rid of variation and all that sort of thing. It's this concept of driving out variation from your process. And, we have a lot of variation still in our healthcare processes. And then they mentioned some mistakes in healthcare versus other industries in the way we implement it, but it's not really critically important information. Let's talk about high reliability organizations and their key features. They have a preoccupation with failure. That's not a negative point of view. It means they are just tough on it. They are looking for ways things can fail. They are pushing to understand where will a process fail and then redesigning it to get rid of the opportunity for failure or variation to occur. They have a commitment to resilience, the development of capacities to detect unexpected threats and contain them before they cause harm or to recover from them when they do. And then a sensitivity of frontline operations. This is an anti-hierarchical concept. The attentiveness to issues facing frontline workers, both when they're looking at things that have gone wrong and also when they're designing things for the future. And I suspect you've already worked in places where that doesn't happen, where you get top-down decision-making about things that, the people at the top probably haven't done in decades. And they're sitting up there or over there or wherever they are, making all these decisions like they're still relevant. They're no longer relevant. Once you leave frontline service in healthcare, I mean, your relevance is gone like that. I lived it. I mean, you just, this is a changing industry, but we oftentimes see that executives and physicians who aren't in clinical practice anymore in administration are making decisions they have no business making because they aren't doing the work anymore. So that's what that's about. The application of these high reliability principles then is applied to hospitals is described in the chapter. And then some of the challenges of how to apply them is talked about, but we really get into it more later. Let's not spend more time on this slide. So conceptual challenges with the safety culture. There's the theoretical appeal and versus the practical implementation. It sounds great at the board. When you're at your board meeting and we're going to have this high reliability organization and everybody's, oh yeah, that's just great. Until you start squeezing individual people about their variation in their process. And sometimes they're people who are very influential. Oftentimes, like surgeons, bring a lot of revenue to an organization. The financial success of almost every hospital is based in its surgery, not in its medicine. Its surgery is important. So you get these kind of mini kings walking around, surgeons who feel untouchable because the thing that's never really said out loud, but I'm saying it, is they bring so much money into the organization and they have the option. They're not there under court order and they're not employees. They can just go down the street to the next hospital and do their surgeries there. They would welcome them, so they get to be this kind of untouchables. And that's where the real rub starts coming in, when you're really trying to get serious about quality and reducing variability and all that sort of thing. And I don't think, well, here I am. I'm no longer relevant. I haven't been there in 10 years, but I don't think it's as bad. When I left 10 years ago, we had moved on culturally in most organizations. That isn't so strong, but I lived through this introduction of these concepts when I was in a management job in different hospitals, and it was bumpy. I mean, we had people just pounding their fists, and you can't tell me what to do, and it was just rough. But we got through it, and the way we really got through it, especially with surgeons, is we had a few enlightened surgeons who called the other guys out, or men and women out, on their bad behavior, and we got through it. So things got a lot better. How organizations might commit to vague safety goals. Well, that's so nobody's ever accountable. Keep your goals vague. You never have to worry about anybody being accountable, anybody having any consequences of not following rules. And then the dichotomies in a safety culture, we pretty well talked about it. Top down versus bottom up, just covered that. And the no blame versus accountability frameworks. Keep the goals vague, you know, that's like, no, we tried. Or, oh, well, that kind of an attitude. Um, so then they give this little case study about two women whose names are very similar. Of course, this is all just fictitious, but the idea that they were misidentified, and one of them was a neurosurgery case who ended up about to have a heart cath procedure of some sort. It was pretty extreme, but it kind of showed you how things could have happened and why we have systems like we do now, like barcoded ID bands, for one. And, it wasn't, in my span of practice, we didn't routinely ask people to tell us their date of birth. I mean, that's fairly new. What's your name, date of birth? When I see patients now, I go in the room and say, hi, tell them who I am. Say, can you tell me your name? I have it right in front of me, but they tell me their name and I say, can you tell me your date of birth? So this patient ID thing is really a fairly new concept, but it's really powerful. And, periodically I will go through that. I don't know, not very often, like about as often as you might drive off without paying for your gas. But it's happened to me where I've gone in, had the chart open, I'm ready to go, and I got the wrong patient open. I mean, I'm looking at the wrong record. Thought I had the right record. But if I hadn't done that, like, tell me your name and your date of birth, and I'm looking down going, nope, that's not you. We could have been off to the races. Where I work, unlikely any really horrible outcome would come, other than I'd have a lot of rework to do to go back and have to fix all my documentation. But if you're in an operating room, or if you're, in an intensive care unit and you screw up like that, and you're reading a record, because for one thing, patient's not talking to you, they have an endotracheal tube in their mouth, into their lung, they can't talk. Yeah, then it gets really dicey because you can really screw up. So that was the whole idea behind that, the case study. Then they go over miscommunication and authority gradients. We've covered authority gradients before, but they bring it up again. And then they kind of move on to measurement. Get onto the measurement. Oh, here's a barcoded ID band. I did a lot of slides over this content. Let's talk a bit about the culture of low expectations. That's an important thing. We have probably to some extent still too low expectations. We just think there's so much variability in the way people get sick, and people are individual, and you can't generalize it, and blah, 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 goes on and on and on. And I participated in it too. I remember in my own management career where, and you've heard about this before, because we talked about it earlier in the semester, one of the hospital acquired conditions that is preventable is pressure ulcers. And I remember coming into a hospital new. I mean, I wasn't in nursing or management, but I'd moved it from one hospital to another, and I'm coming in, I'm the chief nurse, and they had a high pressure ulcer rate, hospital acquired pressure ulcer rate, plus a lot of people came in with pressure ulcers because a lot of the patients came from extended care facilities. And they were old and they had poor nutrition, blah, 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 all these risk factors. And I remember hearing from the people there in the organization, well, they're just old and they, their nutrition's terrible and blah, blah, blah. And nutrition is a key factor in wound formation and wound healing. And I was kind of like, yeah. And then, I'm driving home, like, I'd only been there a month or something. I thought, wait a minute, what am I thinking? That's the culture of low expectations. They just said, oh, we can't do better. Well, we did better. We got it under control. And a lot of people didn't have to suffer pressure ulcers. There was a guy, he's not mentioned in this reading, but there was a physician who worked for the Institute of Healthcare Improvement, and his name was Lucian Leap. I think Dr. Leap probably is no longer with us because he was very old when I'm thinking back into the 90s when I saw him and read his stuff. And he used to have a talk where he would talk about people so proud of the fact that they only had I don't know, some 15% pressure ulcer rate or something, which would be just horrible. 15% of your patients are getting hospital-acquired pressure ulcers. That's just like set your hair on fire bad. But take any of those quality indicators. There were people who were like, well, 85% didn't get one, kind of a thing. And he used to call it cream of the crap. And that just stuck with me because we do get this expectation of crap, and so people are very proud that they've improved it from, 17 to 15%. What? It's nuts. But it is a really potent force in culture of safety that people just like, well, we did everything we could do, and they haven't. They just haven't. But it isn't on an individual level. One of the things that chapter is trying to make the point is it's the culture, it's the whole organization, or at least parts of the organization. You don't look to individual providers. We're talking culture now. So moving on to that, how do you measure it? Well, they go through a couple of different things. They talk about AHRQ. I think they tell you what that is. That's the Agency for Health Research and Quality. And it's not part of CDC, but it is part of the National Institutes of Health. And they produce a lot of quality materials. They monitor quality measures. They produce reports and give them over to Medicare. AHRQ is a very credible government agency. And they also mentioned the Safety Attitudes Questionnaire. And I used to know where that came from, but it's a commonly used one. So anyway, this guy named Peter Pronovost is a intensivist, and he worked at in Boston, Brigham's probably. And they did a study. He and this guy Sexton did a study, and this is going back into the 90s, I think. And they showed the variability using the SAQ survey among a segment of hospitals, and their study looked like this. But respondents reporting good safety climate as low as 40% and as high as 80%. And the norm hospital X fell here. But then they looked at this hospital X, which was part of the 49 or whatever. Well, no, actually, it was a bigger sample than that. But that hospital had 49 units. So then they looked just within that hospital that I just showed you, and look at the variation unit to unit to unit to unit here. And why do you think that would happen? Because we're talking culture. Why would you think even within the hospital there would be that much variation in the culture of safety? You got any ideas?
I do not.
Me neither.
The manager. Because you have all kinds of things built at, in the organizational level, but the place where the culture meets the provider, the nurse, the tech, the x-ray tech, the PCA, whatever, is through the manager. And so these people down here, these guys, they're sleeping through their job. They're not doing their job. They're looking at data and going, oh, well, that's the best we can do. These people over here are doing the stuff they're supposed to do, and it's working. It really is, there are whole hospital effects, but it really happens unit by unit by unit by unit. And then there's also an issue of a higher level accountability, because why are these people still working here? Look at that. That's horrible. I mean, this is a snapshot, but let's just assume, and it's a pretty likely assumption, this has been going on a while. And when I come into a new organization, fresh eyes are really helpful for a while, but you lose them quick. But when you got them there, you want to write it down. Yeah, there is variation. You can see it. You can walk in there, look around, look at the data, go out, look at the units, talk to the staff, talk to the patients. It always lines up. You can tell what manager is either afraid to do their job, that's a different problem, or they're just lazy. I don't mean to, it's pretty pejorative. I don't usually talk like that, but or maybe they're impaired, or maybe there's something wrong, but this has got to go. You can't sit there with this. We want everybody up here. So anyway, that was what their study showed. And at the time it got people pretty excited. Some happy, some not so happy. So differences in the perception of safety. There are discrepancies between nurses, physicians, and administrators. And a guy named Singer came up with that. So why would that be important? Why do we care that nurses see safety one way differently than physicians or different than administrators? Well, one of the things, and I say this, just full disclosure, I'm a nurse, so, I probably have a bias, but it's been reported by non-nurses who study this. In hospitals, nurses are the most influential group around safety, not necessarily quality, but safety. And the reason is I think they use the word like they're the backbone of a hospital. Well, they're there 24/7, 100% of the time, one. And two is nurses are either doing or directly observing every patient care process in that hospital, irrespective of who the doctor might be or what, where they're going. There's a nurse there. That's just the way hospitals work. It isn't anything great about nurses. It's just the situation. So when the nurses are doing their job in protecting the patients, you have a safe hospital. When the nurses are in a culture where they just say, forget it, or they're getting beat up for calling somebody out about safety issues, and, they got to behave well. I'm not saying they can run around being, nasty, but if you want a safe hospital, you got to make sure your nurses are doing the right thing. So what about doctors? Why not doctors? Well, yeah, doctors too. I'm not saying doctors aren't important to safety. They are. But it is not an uncommon scenario for in the place that people usually look at it is in the operating room with surgeons. I really like surgeons. I sound like I'm riding the case, and I'm not. But, just because it's so easy, but it happens in the ER, it happens in the OB department, it happens everywhere. Med surge, the whole works, everything, top to bottom, behavioral health, you name it. Nurses are there nagging at doctors to do the right thing every day. It's just the way it works. So, teamwork. I'm trying to remember what they said about teamwork. There's one thing I didn't think we got to yet. And that's the production pressure. Did that make sense to you when they were talking about production pressure? Where is production pressure? I thought I had it in here. Production pressure is we're too busy to do it right. We're going to just shortcut because we're busy. That's production pressure. Hurry up, get them out, get them through the ER, get them out of the, move them quick out of PACU because we got more cases coming in. We want to stay on time and we want to blah, blah, blah. And they talk about, I know a couple of the examples, and oftentimes you'll see examples reflected back to the aviation industry because we've mirrored their work, basically. We've taken their work, applied it to healthcare. That's a little overstatement, but not much. I'm not going to take a lot more time looking for it. Production pressure. Well, where did that go? Yeah, I don't think I have anything more to tell you about it. If you haven't read the part, go back and kind of read it. They talk about fast food restaurants and different places where they have built the system for throughput. We need throughput in hospitals too, but not at the expense of safety. Now, here's this thing about it's more along this authority gradient, but it's also about being distant from the work. You will see that in many hospitals that administer these surveys, culture of safety looks different at the front line, and that would include physicians at the front line, nurses at the front line, physical therapists at the front line, everybody, pharmacists, all those people. Front line looks different than the same survey completed by people higher, up in the hierarchy. And the leadership thinks things are much safer than the people doing the work. Isn't that rich? They do. So that's pretty common. And part of it is just hopefulness and wanting it to be better. Part of it is, well, one of my goals, one of my maybe even my compensation related goals, or something that could derail my career is I have to make sure I'm maintaining a culture of safety. So I just think I do. That happens. But the problem is if the top of the organization doesn't get involved, if the most powerful, most highly compensated people with the most power in the organization don't get serious about it, then no matter how great your frontline people are, they will never have the kinds of supports that they need, the resources and all that, to really affect the improvements in safety that you really want to have. So when consultants come in and work in organizations, whether it's at a whole corporation like, all Henry Ford, or in an individual hospital, or even an individual department, they go right to the top. They look around, they see what's going on, and then they go right at the top and have, direct conversations, because they're getting under contract, they're going to get paid one way or the other. They have no pressure on them to not do it. They talk to the board as well as the CEO, and the board's who hires the CEO. So, this is a time when you really do need to impact things at the top to get things to happen further down when you're building the safety culture. I don't think we need to look at that slide. More on that. So I think we covered the consequences of steep hierarchies. Oh, here it is right there in that aviation disaster. I think it makes sense that if people are reluctant to speak up, then, you can just drive right off the cliff and nobody's going to tell you if you're the, person, the physician or somebody doing something. And the same thing is true with management. If you're not going to your manager and going, hey, things are loose out here. Things are not going to go well. We got to do something, because you get a response of, yeah, just go do your work. You don't like it, go somewhere else. If that's the kind of culture you got going on in your organization, you're going to have a serious safety problem. Culture of low expectations. We talked about it earlier. I don't have anything more to say. That's the cream of the crop. Chasen was the kind of the colleague of Lucian Leap. I mentioned Dr. Leap, but it could have been Dr. Chasen just as well. Poor communication, changing default behaviors to prioritize safety is what has to happen. The default behaviors, like, I know I'm supposed to, double check my insulin and heparin before I give it, but nobody's right here and I'm busy. That's the kind of attitude that leads to disasters. Nothing really there I want to tell you about. Here's the production measures. Ooh, way back down here. So we talked about that. And balance. Yeah, you got to have production, but you also never at the cost of safety. Ooh, I put a lot in here on that. Okay, on to teamwork. So we've talked about crew resource management. At least I've said those words here, and I think it's been in the book before. Again, borrowed from aviation industry, but it talks about communication and situational awareness. And there's a lot of information on CRM. I'm not going to repeat all of it for you. The evidence supporting teamwork training is that when they took that into the VA system, they reduced patient mortality, not just, like safety incidents, but patient mortality reduced 50%. That's astounding. It must have been a snake pit to start, as to be blunt. I don't know how you could get a 50% reduction in mortality simply by fixing your safety issue. If people were really dying from safety related issues at that rate, that's horrific. But that's what the data shows. That's what they report in the book. But it does work. It really does work. And it improves the culture and outcomes, both improve. Trust is big. But as big as trust in one more thing about CRM. The other thing, they talk about trust a lot. Respect is a really key issue. Everybody it's supposed to be a level playing field, no matter what your role is here. When it comes to talking about safety issues, everybody has the same power and the same voice. And at least that's the aspiration when it works well. And that's what the aviation industry is about, so that the captain of the flight can't just override people, just blow them off. Can't happen. If it does, bad things happen to the captain. It gets reported, they're monitoring those cockpits now. They know what's going on up there. They're listening. So, they just got real serious about it, and it makes a difference. Have you heard about many plane crashes lately? No. 40 years ago, yeah, a couple of years, 3, 4, 5 a year, maybe in the US. No, not anymore. It isn't because the planes are better built. Maybe a little bit around the technology, the avionics and all that stuff, but it's mostly crew resource management. And when they look back at those debriefs on those fatal plane crashes, it was almost always, they didn't run out of gas, and they, forget like, all right, a bomb blew up, okay, fine. But it was always about somebody wasn't communicating in the cockpit and they flew the plane into a mountain or something. So what are best practices to evaluate team training? Regular feedback loops and continuous improvement. That's kind of it. Now we move on to checklists. Checklists, and this guy Gawande in his manifesto. I don't know if I am so accustomed to having checklists for so long that members of my family think I'm nuts. The ones who aren't nurses. The nurses all understand. We all kind of have our own, sub-family. But I got checklists for everything. If we're, I don't know, cutting the grass practically, I got a checklist in my head, if not, writing it down, which isn't as good. Not as good. Checklists really improve it. I don't feel really safe anymore if I don't have a checklist. I want to check it off, make sure everything happens. It really cuts down on errors. But when we introduce checklists in a major way in healthcare, oh my God, people were so offended. These simple things I do all the time, that's a problem. Simple things I do all the time, oops, that's a problem. But we didn't know it was a problem then. These automatic, heuristic is another word for it, things I just do automatically. We want a checklist, because you get little skips in your, we know more also about how the brain works. And if you get interrupted, get a distraction while you're going through your heuristic, you can run off course. A checklist will bring you back. That's why we want you to use a checklist. Anyway, he says we all have means to make some of the most complex and dangerous work we do more effective than we ever thought possible, but the prospect pushes against the traditional culture of medicine. Gawande is a physician, with its central belief that in situations of high risk and complexity, that what you want is expert audacity, just the autonomy. Checklists and standard operating procedures feel like exactly the opposite, and that's what rankles so many people, mostly physicians, and they were rankled. They didn't like it. But we persevered, and now we have checklists on a lot of stuff. Yeah, there's that. I thought this was interesting. This, if you can see it in the book, I just pulled this image right out of the book. But they show you a good checklist over here, improved, and a poor checklist. And why? I thought it was very interesting. I've never seen anything like this before. But I'm not going to walk through it. It's so tiny you won't be able to read it. But it's in chapter, what are we on, 15? And it's very interesting. Ways you can even improve your checklist. Good. So then we get to the rules and the rule violations. We've talked about this before. The workaround, remember I was talking to you about, we brought barcoded medication administration so that I, scan the drug label and I scan the wristband of the patient and so forth. And I have all these safety things. And then sure shooting, some nurse, because they're busy, decides they'll just circumvent all that safety and go print off a bunch of Pluie labels, stick them on a piece of paper, put it on the med cart, and just completely undermine the whole thing. That's what they're talking about here. So it's not a new concept. You've seen this before. They use an example here of the railroad shunter's top reasons for workarounds. I didn't put it in the slides, but it is just, I can tell you what they are. I got it right here. I mean, it almost made me laugh. It was like, and this is in the railroad industry, not healthcare. Excuse me while I scroll. This is a quicker way of working. That was the top reason. Second one was an inexperienced shunter. The shunter is the position. I don't know what a shunter does. I guess they shunt. Time pressure, high workload, shunter's lazy. A skilled shunter can work safely this way. This is without following the process or using checklists. The rule can be impossible to work with. Design of the sidings make the violation necessary. So something in the environment, you couldn't ever do it that way. So I get to just do it the way I think is best. Management turns a blind eye. So there you go with that variation within a hospital. I said, look down here. Problem is the manager. That's the blind eye. Physical exhaustion. That we're going to talk about, I think, in the next chapter. No one understands the rule. It is more exciting way of working. That's horrific. It is a macho way to work. There's a certain amount of that goes on, and the rule is outdated. So there you go. Yeah, so addressing the root causes of rule breaking is a good idea, but hard to do. But what you're looking for when somebody's breaking a rule is there a legitimate reason why I built this process that they really can't do it? You really can't just assume that they're being careless. You need them, meaning the people who are doing the rule breaking. You do need to do a root cause analysis of why is the rule being broken. And sometimes you're going to find out that the systems don't support the rule. And then you got to change the systems or change the rule. But generally, the rule's right, systems aren't right. I think that's the whole point of that. We talked about this already. The role of leadership in safety culture. The leadership's influence on safety initiatives is you just don't tolerate it. I mean, you help people. You don't just walk out and like fire everybody, but you got to get it known that you're not going to put up with a 15% rate of hospital acquired pressure ulcers, or you're not going to accept, medication errors due to patient misidentification. That's 100% fixable. No way. We're not going to take variation there as, oh, well, that's just what happened. In setting a strong tone regarding safety priorities. And, if you get a real, malcontent that's out there and just going to break the rules because, damn it, they want to and they think they can get away with it, you might have to take one of those people and just get rid of them. Move them out of your organization. And that will have an effect. It sends a message through the culture that you're serious. And, you would hope you have nobody that gets in that position, but if that's what has to happen, then that's what has to happen. So there you go. Yeah, that's enough. So I'm gonna move on to chapter 16, but what questions do you have before I do that? That
I
all
don't,
makes sense?
yeah, it makes sense. Yeah. I don't have any questions.
Yeah, no questions.
All right. So now we're going to talk about workforce issues and patient safety. And these refer to factors affecting the healthcare staff, including training, competency, staffing, and working conditions. A lot comes up in nursing around staffing. I could go hours on nurse staffing, but I will spare you that. So nursing workforce issues are staffing shortages, workload, and burnout. We developed something called a rapid response team that caught fire in the 2000s, I think. Right, yeah, I was at Livonia when that started rolling out, so that would have been after 2003. Um, and they've had a real effectiveness. Interestingly enough, a rapid response team, you know what a code, a resuscitation code blue, whatever they call it, is when somebody actually stops breathing or they lose their blood pressure entirely. I mean, they are in the process of dying. We call a code. And we run up there and zap them and put IVs in them and intubate them if they aren't and all that. That was a code. That was all we kind of had up until rapid response came in. So what would happen is if you had a patient deteriorating, then the nurse taking care of the patient was talking to the doctors, trying to get a hold of them, trying to figure out what in the world's going on. Well, sometimes that was a little slow, I mean, residents are generally around, but if they weren't, I mean, you can imagine it was a slow process. If people started, the vernacular is crumping in front of you, and sometimes you couldn't get the attention you needed, you would then end up at the endpoint, which is a code. Well, the percent of people who survive a code is about 20%. If you arrest, even in the best hospital, if you have deteriorated to that point, the save rate on codes, no joke, is about 20 to 25%. So that's a bad thing. So we got this great idea. Well, let's say that the nurse doesn't have to call a code per se, but they we could have a group of nurses and respiratory therapists and generally a physician designated as a team 24/7, 7 days a week, and they're the rapid response team. And then if a nurse is even just kind of worried about, well, I don't like the way they're breathing, or I've been, their blood pressure is just kind of tanking here a little bit and they don't look so good, that they could just call a rapid response and they run out and do the full assessment and have all that sort of thing. It's a great thing. We saved a lot from letting people deteriorate to the point that they were coding. So it's a great thing, but it does band-aid a more fundamental issue of how is our system built so that a lot of people know something's going wrong, but we can't quite mobilize what we know how to do to deal with it, without having to build another layer on it called a rapid response team. And that occurred to me. We were so happy here in Livonia with our rapid response team and how great it was. And the nurses were so thrilled, that they had this resource. And I was sitting there in a meeting or something, quality meeting, and a person that I had worked with over in Ann Arbor for years and years and knew very well. And she's a physician and very much engaged in quality. And she was sitting on our committee because we would send people to different hospitals so you get that fresh eyes approach. And so she's sitting next to me and somebody's giving a presentation on our rapid response team, brand new thing, been out maybe 3 months. And she looks at me quietly and she goes, "That's way too many rapid responses." And I'm like, "What?" She goes, "Yeah, you shouldn't have that many." And I was like, oh, well, we did change things after that. It wasn't I didn't change them. I mean, we as a group, dealt with that, but she was right. Why do you have so many rapid responses? She's used to a 500-bed hospital. We were a 300-bed hospital, and she had like 25% as many as we were having. And there were reasons. I won't bore you with it, but there were serious quality/safety issues. And we were in the process of having just taken over the hospital and getting it in order. And, it was a turnaround situation. So there you go. But rapid response teams are good. Duty hour restrictions. Going to talk about that, the July effect, and second victim phenomena. Here's the problem with nurse staffing. There aren't enough nurses. End of the day. Nationally, there are not enough nurses. And many of us are retiring. We are in a deep problem here. They're going to talk about it, but I didn't like the tone of some of this. I'll just be honest with you. It implies that there is an endless supply of, they mentioned a little something at the end, like, oh, well, you should have a relationship with nursing schools. I'm in a nursing school. Our enrollments are dropping because nobody wants to be a nurse. Well, fewer people want to be a nurse. But the big problem with, and there is a problem with short staffing, it has bad consequences, bad patient outcome issues, burns up our nursing staff, drives people out of the profession, bad, bad, bad. But the problem, one of the problems, or one of the fallacies, I guess, that makes us not look at the real problem is it's just those blockheaded chintzy administrators who won't give us enough nurses. That is a common belief of staff nurses. That chief nurse or that CFO or whatever, all those other people over there, they're just so damn chintzy, you know? They don't even know how bad it is out here. Well, that's probably true. They don't. But that ain't why you don't have enough nurses. The reason is we can't hire them. We can't find them, no matter how much money we put out there or whatever else. And then the hospitals are getting squeezed financially. So it's a huge problem. I'll get off my soapbox. We'll just move on with the slides as they're written. But you're going to get this tone like, well, you know, they just don't put enough nurses there. Well, if it's that easy, we would, right? So, overworked nurses who have less time patient interaction. Yes, yes, yes. Look, we've got the best data, and nobody's ever improved on the data, although it's been replicated over and over again from a nurse researcher, excuse me, by the name of Linda Aiken. And she was at a Pennsylvania hospital, I forget where, University of Pennsylvania, I think. And she did the kind of the first study. And and I want to tell you, Linda Aiken did this in the 80s. She showed unequivocally that the nurse to patient ratio made a difference in the outcomes of post-surgical patients. Her data was so good, the study was so well designed, and it was big enough that there was never really any way anybody could refute it. And it's never been disproven. Now, what, 4 decades later, it's never been disproven. Nurse to patient ratios and or hours per patient day, or there are different ways that we term it, but the number of nurses for a patient makes a difference in the patient's outcome. No question about it. So, you know, there you go. Nurse to patient ratio, yeah. So this is started with Aiken. Hundreds of studies since all give the same answer. Excessive workloads contribute to burnout. Yes, we know. Every additional patient per nurse, the mortality. Yes, that's right. So this is not news. Just, you know, we've known this forever. Talked about rapid response teams. Wonderful idea. And I will say this about it. What we're looking at now, because we just cannot clone nurses, is ways to effectively make that nurse brain kind of have the ability to touch more patients. So there are monitoring systems, there are remote nurses in the hospital who are watching certain cases for you, where they're kind of watching people or doing certain tasks. We're bringing licensed practical nurses back. They had a big part in hospitals through the 70s. And then all of a sudden we decided they didn't have enough preparation to deal with these very sick people. And so we sent them all out to the nursing home. Now we're bringing them back. So there's all kinds of stuff we're doing. But it really, my concept is we're trying to get as much impact out of that nurse brain as we can. And they can't do everything for everybody if we're going to make that happen. They've got to be able to delegate. And that's what we're trying to redesign. Actually, we had systems before that we're probably going to end up back to called team nursing. Anyway, positive outcomes, great. Reduced in-hospital arrests and unplanned ICU admissions. Mixed results. Some studies showed no impact. These are probably the ones with no impact were the better hospitals. Just saying. Duty hour restrictions. This is for residents. Prior to about 2010, I think actually we have the data in here. There's a group called the ACGME. It's the accrediting body for graduate medical education. the certified residency programs for all the allopathic, meaning MD residencies, and there's a complementary organization for the osteopathic one. Anyway, they really cracked down on how many hours residents could work. So residents, if you don't know, are physicians, fully licensed physicians. They went to medical school. They passed their medical licensure examination. They are out getting practical experience under the supervision of other physicians in an organized way in a residency. And that's, tiered. There's a first year, second year, third year. And then the fourth year, if they do a fourth year, is called a fellowship. But that's how people develop specialties. So surgeons do it, internal medicine physicians do it, pediatricians, et cetera, et cetera. They're residents, and then they got a license, but they don't have their certification yet. So when they complete the residency, then they take another certification exam, and they become board certified in their specialty. So that's what we're talking about. These people who are still in training under supervision, but they're providing care, and they're really fully functional physicians. They used to work ridiculous hours, just ridiculous hours. And they would have untold numbers of patients and all that. And ACGME came in and just said, that's it. We have too many safety issues with this, and we're killing these young physicians, and you just can't do it anymore. And if you keep doing it, they're talking to the hospitals running this residencies. If you keep doing it, we're going to pull your residency program. Well, that's a big deal. The residency program, one, feeds doctors to the hospital. They need doctors because people are retiring and they're building service lines. Two is the hospital gets a whole lot more reimbursement from Medicare for every FTE of resident that they have. So there was a lot of teeth in it. When ACGME says, that's it, we're done. We're not going to certify you guys if you don't come into compliance. So all of a sudden, the number of patients that were covered dropped. So then we had a bunch of patients out there whose doctor was home in bed. There was nobody covering them. It's the nurse and the doc home in bed, back to the 50s, and 60s. So then we went out and got a bunch of people like me, nurse practitioners and PAs, and we hired them and brought them into the hospital to do all the work that the residents have been doing. So anyway, we're somewhere in between now, but they put on that duty hour limit, and it has had significant positive improvements. And really horrible things happen. I have someone I know personally lost a member of their family in a very respected hospital that you've heard of. It's in Ann Arbor, and that organization also has a very famous football team, but they shall go nameless. And the person got this thing called thrombocytopenic purpura, which is a life-threatening condition, but fixable. They got there, they just diagnosed them correctly, and they had them in the ICU, and they were going to put a big catheter, vascular catheter into their chest, into a major vessel in their chest, because the treatment is a thing called plasmapheresis, which is a lot like dialysis. So they stick this temporary thing in, and then bingo, we run the machine and the person lives, yay. So that was the plan. And while they're waiting in the waiting room for them to put this, it's called a Sorensen catheter in, they're waiting and they're waiting, and they come out and they said, the person died. What had happened was the surgeon, who had not been to bed for 30, this came out in the lawsuit, hadn't been to bed for 38 hours, had been on duty for 38 hours continuously, was up there working by himself, stuck this thing in, and what he did was he lacerated a major vessel in her chest, and she just exsanguinated into her lung. Now, this guy probably put in a bunch of these before, but not when he hadn't been to bed for 38 hours. So it's one real life example I know of, but there were many. Enough. Let's move on to the July effect. Don't get sick in July. Everybody in healthcare knows this. Why? Because that's when all the new residents come. Now, you don't need to really worry because the nurses are there. And first year residents don't get much respect. So Nurses don't have any hierarchy thing. They'll just whap them upside the head, give them a dope slap if they're doing something wrong. That's really how they get their initial uh, orientation to the real life in a hospital is the nurses. Well, and the residents too, but the nurses are there 24/7 all the time. And it's the nurses who get us through July every year. There just aren't enough residents to be around enough to watch them all. So that's what goes on. But, they just bring it up in the book. I don't think we can't really do much about it. I would say orientation and increased supervision is what they're talking about, and more structured onboarding. That's already happened. That happened in the last 10 years, but it came in right after AGME just said, this is it. It's telling these, we're ruining these young doctors and it's putting patients at risk, and we're just not going to certify you anymore, your program anymore, if you don't come into alignment with our recommendations. And so they went from recommendations to mandate, and boom, there we go. All right. Second victim phenomena. That's the person who commits the error that hurts somebody. It's it's a real issue. And I think people are more enlightened overall than they were before, but the best people in leadership and healthcare were always enlightened about this. I mean, if you commit an act, but you didn't mean to, but I mean, something happens, and we know from quality improvement, the majority of them aren't the individual person's performance. We talk about just culture. Do we talk about just culture in here yet? I can't remember. Did we talk about that?
I don't think so.
I think that's coming up. There's an approach to figuring out, overwhelmingly when bad errors, even errors that cause deaths, happen, it is not the individual at the bedside doing the thing. It was the system that failed. They couldn't do anything about it. Then there are people who there are a much smaller percentage where somebody's well-intended and they're trying to do what they can, and they do something wrong. They just forget something, like checklists, they didn't have a checklist for it, whatever. And then this tiny fraction of it are people who really either were just absolutely negligent. They just didn't care. They, whatever. Let the patient die, so what? Not very many of those. Or they intended, God help us, to cause harm. You hear of those once in a while where somebody goes nuts and starts poisoning patients and stuff. In the group of the ones who are negligent, in my experience, they were all impaired. We just didn't know it until after the event. Then, we start the root cause and we start doing all that stuff. And it comes up that, well, their performance hasn't been so good lately. And then we let's, they go off to talk to some people. We get some drug testing. And it isn't always addiction. I mean, it can be mental illness. It can be other things. But in my experience, I've never found one person who was a sociopath. They just didn't give a shit. They've always been impaired. But we didn't know. So anyway, there you go. Cutting right to the chase. But these are the things you do for that. This is just a wrap up. So organizational culture comes from the top. It's all about, giving resources and holding people accountable and continuous learning. We got more slides here. Workforce demoralization. Yeah, it's a real thing in healthcare right now. People are just beat up. They got beat up during the pandemic. All kinds of things are happening. The nursing shortage is a big deal. We keep talking about it as a nursing shortage because there really aren't the same level on a percentage basis of shortages in the other professions right now. And there aren't a lot of technological helpers for nursing shortages. Like pharmacy, we've automated so much that you can spread a pharmacist's brain over a lot more doses, if you want to think about it like that, than you used to be able to. Not so much with nurses. That's why we're trying to come up with some new delivery models for them. It's always a good idea to recruit. That presumes there's nurses out there to recruit. Oh, here's a thing, technology. This was the one I looked at and go, well, that's not what we said a couple of weeks ago. Electronic health records, streamlined documentation. That's not what we heard. It actually, data input is longer than on paper, generally speaking, and that's true. So this is a little Pollyannish, but they do improve access, and that's probably a bigger payback from the time you lose at data entry. Telemedicine and automation, all systems we can use. Let me just look ahead. Leadership's role in staffing, you should staff. Anticipate the staffing needs based on volumes, everybody does. Develop contingency plans for shortages, best you can, then don't have nurses. Invest in the staff, good, competitive salaries and benefits and opportunities for professional growth, all good. Involving staff in decision-making, yes, shared governance, all that sort of thing, we've been doing it. And regular feedback and recognition programs do help. There are financial constraints. There is a clear risk of understaffing, and the solutions here, cost-benefit analysis, highlighting safety investments. But when it comes to staffing, and here their ideas were float pools and per diem, that still implies that there's a bunch of nurses out there. There aren't. That's the problem. And I think, it's a public policy problem for us at this point. And not all countries are having this. I mean, this is not worldwide. And we've faced it before, and we've allowed immigration of nurses, encouraged immigration of nurses. When I was early in my career, it was the Philippines. We were getting all our nurses many nurses from the Philippines. Where we're getting thank God, a lot of very well-prepared nurses right now is from India. But there's a limit to their supply of nurses as well. So their immigration is kind of a short-term fix to some extent, but even then we can't seem to fill the hole. But we need to really look at why it's a great profession. Why it can be a great profession, wonderfully fulfilling, great work, pretty well compensated, and nobody wants to do it all this. I mean, obviously some people do. We have students, but compared to it doesn't have the same appeal. Let's just say that. And that we got to figure out, because we don't really have a solution, and we're all getting older, and nurses are getting older, and older patients need more nursing care than younger people who generally don't need much nursing care. So it's a real crisis. Oh, competencies, good idea. We do them. Resilience. So this is work-life balance, wellness programs, and community building, all good things. Sometimes it gets kind of poo-pooed. This thing can hit the chopping block when finances get tough. It's a bad thing to cut. And not everybody in your workforce will engage, but you at least want to make that offer for them. Here they talk about policy reforms, educational partnerships, and data-driven approaches. We use analytics to predict staffing now, just so you know. Problem with the author on some of this stuff. Team-based care, great idea. And that doesn't mean like just nursing and patient care assistants and that sort of thing. They mean multidisciplinary rounds with physicians, nurses, pharmacists, physical therapists, if it makes sense, occupational therapists, respiratory therapist if it's in the ICU, communication tools, and then conflict resolution, training and effective communication and teamwork. Burnout prevention, some strategies for that. They all look about the same. Staffing ratios, yes, we know. Everybody does staff that I know of, and I know of a lot. Try to use some kind of an acuity system. Here's the problem. Medical complexity, the severity of illness doesn't correlate well with nursing workload. It isn't completely dissociated, but we can't simply staff, I wish we could, based on their ICD-10 code, So we chunk them out, like, well, we know what an ICU surgical patient looks like. We know what an intermediate care patient looks like. We kind of have these work efforts kind of chunked out. There was a period where nurse researchers and administrators were trying to get a reliable, easily obtainable method for collecting data and being able to really define the nursing workload. And eventually I think we've all just thrown our hands up. I mean, it just you can't seem to get it done. It is a really difficult thing to define. If severity of illness worked, or if we could count on ICD-10s to drive workload, I mean, to define workload, it would be a breeze because everybody's got ICD-10 codes because you have to code them based on their diagnosis. But the ICD-10 code is pneumonia. Well, is that a pneumonia of somebody 33 years old or somebody 93 years old? Or, we could even say how many comorbidities they have. But at the end of the day, we use the ICD-10 code to assign the DRG, which will link to payment, but the nursing workload never comes into that. So we get into all this jam where if you get high dependency patients who are unstable and need a whole lot of nursing care, either because they're not mobile or because they're physiologically unstable, those are the major things that drive nursing care. But they have just kind of a lightweight medical diagnosis. You're not going to get much money for that case, yet it requires a whole lot of expensive nursing care. So it's just a system. You don't have to fix that. It's not on the final solve the problem. They have a study of somebody who fixed their problem. That's good. You can read the study. It's good. It's good. I mean, good stuff. Engagement strategies, policy goals, and collaboration. All good. Lessons learned. Yeah. Interconnectedness. Patient safety is directly related to the workforce well-being. Proactive measures, anticipating challenges, continuous improvement, and collective responsibility where everybody is pulling on the oars for safety. And our conclusion is addressing workforce issues is crucial for enhancing safety. Investing in the workforce leads to better outcomes for patients, and a call to action to encourage all stakeholders to prioritize development and support. And, tell everybody you know to go to nursing school. That will help a lot. So that's it. What more can I do for you guys?
Is that so that exam is due on Sunday?
Yeah, I think I said it on Sundays. I got a problem. You got something going on, Johnny? You need an extension?
Oh no, I was just clarifying.
Yeah, it closes on Sunday right now at midnight.
Okay, that sounds good.
Okay.
Yeah, that's fine for me too.
Okay, good.
Mhm.
Well, I hope that made some sense.
It did. Yeah.
Good.
Mhm.
Good, good. All right, guys. If there's not anything else you need, I'll say goodnight.
Have a good night.
Okay. Yeah, good night.
Good
Thank
night.
you.
You bet.